Yeah.
What about like the issue of like being sweaty?
Oh yeah.
It's like hair scrubs and it's like you just feel gross.
Yeah.
You
changed.
embrace the gross, I guess.
I mean, I changed.
I guess that's how you guys got to see.
You're talking about the worst
How to get some exercise.
contact situation, you have to figure that out too.
Oh no, I'm like
To
so
change your
prepared for
dailies.
that.
Halfway
You
through the
don't
trip.
understand. I bring like face wash and stuff.
Oh, do you? You have like an overnight kit that you bring?
Like
definitely
with me
bring
at
it.
all
You bring your face cream too?
Dude,
Yeah.
washing your face is like so refreshing.
I know, I have to do
I
that.
shower on it overnights.
Yeah.
Just kind of like it's
What we're talking about,
Yeah,
I would
this is great.
on the...
real
Yeah.
time.
Real talk. This is real top wellness.
Prevent those adverse outcomes in ORs.
Alright. Are we supposed so the schedule I saw said upstairs 2 floors, but did anybody badge you in down here?
No.
You
So
should
we
have
have to
to
do
do
there's
there's that.
badging, yeah.
Okay. Hopefully we don't get kicked out. So what we're gonna do here is just go through a couple case scenarios and talk about fire safety. Anybody find the fire extinguishers today? I know. Nobody.
The room that I was in was giant, and there's a lot of stuff in there. So that's my excuse.
I'm not gonna give an excuse. Excuse.
Yeah, no, it's so big, I can't walk around.
Yeah. Oh my goodness, there's a fire extinguisher in every single OR. It's usually by the central core area, but on the inside of the door. All right. I'll let you guys slide up. This is Joe. Yellow. Okay, so we're going to talk about positioning, we're going to talk about fire safety. Bear with me, I know it's the afternoon, it's been a long day, you guys got to do pretty awesome. So, we'll just present a case here, and then we'll talk about a couple of things. What do you want? Hello? It is? Yeah, that's okay. These are based on how you're aware. Okay. Yeah, no worries. That's okay.
I didn't know that you rinsed it this much.
No worries. But like, okay. Alright, so first case we'll do. This is meant to be interactive. I know it's annoying, but the questions are pretty simple. It's just meant to keep you guys learning. So you have 77-year-old, 120 kilogram female for robotic hysterectomy, ESO. History of hypertension is controlled, takes lisinopril, took a dose a couple days ago. She also has lupus, and she's on 5 milligrams of prednisone a day. And you perform an H&P, they noted her airway exams of body 2, environmental distance of 5, normal mouth opening range of motion, no other significant findings. So essentially you got a 77-year-old, 120 kilogram, robotic hysterectomy, bilateral esophageal oophorectomy with hypertension and lupus. So what are you going to consent the patient for? Some type of anesthesia, probably.
Yeah, yeah, good enough.
Good place to start, team. What else do you consent the patient for?
Arterial line.
Okay, possible arterial line. We went over some indications for arterial lines this morning. Would you just give her, place an arterial line pre-induction for her?
I'll do that after induction.
After induction. And why would you place an arterial line?
Well, I was in, what was her weight again? She was pretty
120 kilograms.
Yeah, I was just, last week I was in a situation and we ended up getting blood gases frequently, and we had to correct some pretty significant hypercardia.
Okay.
And they just ended up being acidotic because they bicarb and some other things. So with that experience, I would go
Okay.
And I'd probably get baseline at least after whatever this case was about to start.
Anybody else? Did anybody else do something different?
I'm probably just have to good PIVs.
Okay.
Because how old was she?
77.
Okay, never mind, even online.
I feel like anybody else.
No, I mean, she's older.
Anybody else?
I don't know about, how does the lupus account in the sideline, right? I don't know, it sounds something I don't know.
I mean, so lupus, you want to think about hypercoagulability, steroids, with another immune suppression. That's scope of this lecture. She should not 5 milligrams a day. But so I probably wouldn't place a line for this lady unless I had a concern. She only has hypertension. She's 77. She's obese. She has significant sleep apnea with pulmonary hypertension, and hypercarbia might be an issue, and hypoxemia, and maybe. But I probably wouldn't start with that. To be honest with you, if she tanked on induction and were struggling before they jumped the arms, probably do that. Yeah. What else?
She's going to be intubated, so she's going to be in steep middle bird.
Yep.
It'd be tricky to get, and they're going to expect the abdomen, so I want to secure her way.
Yeah, I mean, there's not too much. We have our whole form. The only other thing I present every single patient that comes to the OR for is blood transfusion. Surgeons have it on consent, but technically we get it, so we should just consent to it. And I always consent to everybody just in case. Okay, so you said supine lithotomy position, right? Probably some Trendelenburg, right? All right, so we'll talk about positioning injuries. That's really what this is about. So, what kind of positioning injuries would be potentially associated with lithotomy position?
You can get compartment syndrome if your legs propped up for a long time, especially if it's 3 hours.
Okay, compartment syndrome. Yeah.
If you wake them up too soon, you can dislocate their hips.
Yeah, that's true. That would be horrible.
Give me like a perineal lumbar injury.
Yeah, good. And then how does that happen? How does that happen?
When their leg is up, if they don't have like a padding where their legs are resting.
Yeah, exactly. So they put them in those big stirrups, right? And on the side of the stirrups is this big metal bar, and then it's got a big ball on it, right? And it's super common to get a perineal nerve injury in that area because just from direct compression. What else? Lithotomy position. What about prone position? Say it's a different case. Prone.
Unless the vision loss.
Good. Facial edema. Any idea what kind of vision loss? Ischemic optic neuritis. It's like a common board question you guys will see for sure. Prone, it's usually posterior, and anterior ischemic optic neuritis usually happens when there's supine from cardiac surgery or trauma or something like that. EP, prone posterior. Okay. Facial edema. Yep. What else can happen?
Tube migrate
Tube migrates. Yeah.
Just pressure ulcers and
Pressure ulcers. Yeah. Where are the arms are in prone position? So that's nice. You got that going for you. What do they put under the chest to support patients? Ever seen them?
Those
Yeah.
pillow things.
Yeah, they're like big bolsters. Yeah, exactly. What do you think that does to your compliance, your chest wall compliance? Yeah, definitely decreases it, right? And what does that mean for your peak inspiratory pressures in your vent? It's going to be increases. Increasing peak inspiratory pressures, what can happen to the lungs? These are things you want to think about, talk about. You don't need to go ad nauseum with the patient. These are things that happen, right? Okay. And then just of note, those bolsters, if you have a woman with large breasts, they need to be medial to those bolsters. Okay. Otherwise, they get pressure injuries there.
Sorry, the breast being medial?
Yeah. Okay. And then optic neuritis, so fluid overload, low hemoglobin, low FiO2, low blood pressure, all those things contribute to nerve injuries during periodoperation periods. All right, supine positioning. What kind of problems can happen with supine position? Most of the time, that's right. What happens? I think basic. Yeah, ulnar nerve injury. Good. It's the most common neuropathy seen perioperatively.
Is that, you mean just like a plexopathy kind of thing?
Or something like the ulnar nerve here.
Okay,
Yeah.
but
Yeah.
also here, if you have a funky, the arm jacked out.
You can get brachioplexopathies for sure. Ulnar is the most common. How's it going, guys? What are you guys here for by any chance?
Huh?
What are you guys here for?
Here for the anesthesia.
Oh,
yes.
All right, cool. Welcome on the show. Yeah, so how do we position the arms for that? We're talking about positioning. It's very good. How do we position our to prevent an ulnar neuropathy?
Uses triple pillows.
Padded. Okay. And what about
Slight
flexion
bend.
extension? Yeah, exactly.
Slight.
You don't want to hyperextend.
Yeah.
What else? You needed something. What's that? Go with it. Yeah. Supinate. Yeah. So either neutral or supinated hands. Right? All of these things. So neutral, supinated, safe, not fully extended in a neutral, like active position. Those are the safest things. Good. Let's see what else we have here. All right. And then what about the lateral decubitus position? Something like this. What can happen there? Has anybody positioned someone in lateral decubitus yet?
You try and take your neck right there, ears and like compressed.
Okay.
So making sure it's like right in the middle of the donut.
Yeah. And the donut's important for something called pressure alopecia, which actually does exist. Yeah. So as you pressure prevents your hair from growing. People aren't too happy about that. That I don't know. I know we treat alopecia with steroids and it does come back with their injections in the scalp and it hurts like hell.
But if you like lose your alopecia to the beautiful beard, like there's no way you can not get your beard too.
Okay, that's possible too. I didn't think about that. Okay, so lateral decubitus. What else?
And you gotta make sure that the spine is pretty.
Yeah.
So in terms of that, it's pretty straight with the back and not leaning too far.
Yeah. Good. So side to side is bad. What happens if you what happens if you're too far down, like flexed? Two moves. Same thing as extension, right?
Yeah.
You know, if you're on the side, extend back like that, what could that potentially cause a problem with?
Yeah, you're stretching nerves.
Nerves, brachial plexus. What else? Other structures. Super important structures that are like right here.
Oh, your carotid.
Yeah, exactly. So you can have, so arterial is not as common of an obstruction, but venous outflow obstructions are. And when you have venous outflow obstruction, say you're pinched like this or something's pushing here, that causes backflow and increases your ICP. So you have a neuro patient, and this happens in prone position too. You know, if you have a venous outflow obstruction, then you're also going to have worsening ICP, especially in somebody who's got a tumor and you're trying to decrease ICP there. What else do we do for lateral decubitus position, right? Arms are up. Does anything go under the body, maybe? Axial. Yeah, exactly. Why do you think we put an axial? So technically, it's called an axial, but technically it should be called a chest wall bump, right? Because it's supposed to you're supposed to put the chest cavity, like the thoracic cavity, on top of it, so that the thoracic cavity is expanding against something softer, right? You are worried about the axilla, right? Because neurovascular compression, you know, sometimes in a position like that, you get actually artery compression, right? And then you can lose pulses to your extremity. Also brachial plexopathies, right? So we do those, and then sometimes we'll also put a bump under the iliac crest. And that's also to support the hips, so that there's not any torque or pressure on the hips there. Okay. And yeah, so and then with lateral decubitus position, you know, have you guys seen how you flex the bed at all? And flexes in half there. So when that bends the body, or if there's any compression, you can also have IEC compression. Cases of that. What other positions? Sitting position. What do you guys think about that? Beach chair. Proverbial beach chair.
Stroke risk.
Stroke risk. Why?
Because now everything's upright. If you have an error, it goes right to the head.
Okay. What else? So things are upright.
Patients that perfuse the CPP, higher pressures to reach up there.
Right, so you think about cerebral perfusion. Right, so say you got a patient really worried about you popping a line in, where are you going to put the transducer? Yeah, right, because that's what matters. Generally, those patients like put like a liter of fluid before and use it, just so the tank's full. You don't drop as much pressure because they're already cooling their lower extremities. Posterior costal surgery, you know, that's the really high risk for venous air embolisms. Anybody know what to do for venous air embolism? So yeah, that's a good thing to do. Pull back from astroductins, central line, because that air sucks into the brain, goes into the internal jugular vein, right side of the heart, obstruct the vasculature. What else? What do you tell the surgeons to do?
Give fluid in the field.
Yeah.
If it's
flood the field, right? Just make a water interface to prevent any of the air from being trained. Good. And then when they're in this beach chair position, you also don't want their neck super flexed too, because we already talked about. Generally, they say 2 feet. Steve Trendelenburg, I think we kind of mentioned a couple of things there, but let's just review it because they always like to test on it. Steve Trendelenburg position, what are the risks of Steve Trendelenburg position?
increased ICP.
Everybody beaten?
And obese patients still observe an increase of peak pressure, so it's just
Right, it's potential barotrauma, hypoxemia, tachycardia, that sort of thing. Alright. And this is a lot of fun, guys. Alright, so what's the most likely nerve injury in the perioperative period? Yep, Pullman. We see upper extremity nerve injuries more than lower extremity nerve injuries. And then sensory more than motor. And then there's risk factors associated with nerve injuries. Anybody have any idea what they might be?
Diabetes.
Okay, diabetes. Correlated, but not causative.
not obesity.
What's that?
Obesity.
Not obesity.
Super skinny people.
Yeah, so skinny people. Yeah.
Hypertension.
Hypotension, theoretically, yes, but not really proven. It's a good closed claims analysis. I looked at specific things.
Anemia.
No. Tobacco use and hypertension. Why those things? Don't know for sure. You can think about it. They didn't prove exactly why. Those are the big.
Is there like a BMI that they discussed? Or it's just a
Greater than 37.5, they talked about. It's very specific. And then specifically, so that's correlated as well. They also, there's this trend toward males, but specifically hypertension, diabetes, tobacco use. And some people talk about, there are some studies that say super skinny patients and super obese patients, people in the Goldilocks patient, they don't have as many, that sort of thing. Types of surgery are important. Anybody have any idea what types of surgery? Ortho's on there, yeah? Long surgeries, pardon, that's good. Yeah. Vascular. Neuro. Yeah, so neurosurgeries. And then general's in there too. General cardio. So a lot of them, but you think there's a lot of other ones. OB, you think OB would be most like very related because of the steroids and that, but it's not as much. And then what type of anesthesia do you think? Any type of anesthesia have an increased risk?
spinal
Spinal.
or regional.
Does.
Where it's like complete.
Regional doesn't. I know, it's crazy you think so. But they haven't proven it. Maybe they're the same size as big. General and epidural. Yeah. General and epidural. These are just from pooled closed claims analysis that have been filed. And then preventative measures. So we already talked about arm abduction greater than 90 degrees. What else do you think we can do? Forearms. Basic things. Breasts, needle, bolsters, padding, right? Axe or chest roll. All right. So patient complains of left pinky numbness following surgery. What nerve is most likely injured? How do you counsel patients who suffer perioperative nerve injuries regarding expected recovery time? So just roll the dice. This is how many weeks? What do you think? What do you say? Is it going to resolve that?
4 to 6 weeks it will resolve.
Okay.
Well, possibility to resolve, there's possibility that you know, damage, and I think at that time it becomes like neurology.
Good.
See if they can do like some imaging studies to see if the nerve injury damages.
Yeah, so always ascertain sensory versus motor. Motor, always go to neurology right after that. Because they need to go through physical therapy and whatnot, because they can get return of function. But during the return of function, they can get contractures because they don't have enough motion or mobility and whatnot. So you want to prevent those things. And then you also want to consult neurology because some people might be predisposed and have had a previous nerve injury. And with the EMG studies, they can actually tell the timing of the nerve injury. Sensory, most actually resolve in like 2 to 5 days. And then if they don't, the majority actually, after that, resolve in 6 months. So you want to counsel your patient on that. And, consulting neurology is always a good idea. But you don't always have to do it. Yes. The big thing to remember is most neuropathies don't present until 48 hours after surgery. If it happened during the surgery. All right, so what about the case we talked about? So 77-year-old hysterectomy by PSO, hypertension, lupus, 120 kilograms. What's the most likely nerve injury? Yeah. Make sense? Questions about that? Just touching the surface of it all. But there are a few of those topics, probably 3 or 4 are pretty common. All right, who's ready for fire seat? None of you guys look for fire seat, which is
Just throw it out of the fire.
I had a fire in the OR at Denver Health, and
Of course, it's a different health.
water was not the way thing to put it out. It was one of those big knee arthroscopies, and the floor was just covered in that fluid, and the bed cord had like exposed wires, and all of a sudden just started sparking and smoking and whatnot because it was just sitting in that fluid. So smoke started happening, and I started freaking out. So just went and unplugged the bed really quick. But in that case, LR probably wouldn't have been. 5 more. You guys knew the fire extinguisher orders. All right, case presentation. A 27-year-old, 80-kilogram male presents for excision of a light coma from the supraclavicular area under MAC local anesthesia. No significant past medical history. Airway exams unremarkable. Shortly after incision, you smell smoke. All right. What are the 3 important mandatory things to have to start a fire? Oxidizer, fuel, and ignition source. And of those, what's the biggest contributor?
Surgeon.
That's so
Oxygen. All right, anesthetic gases. What of your anesthetic gases that you use in the OR can help you ignite fire? Or can act as fuel for a fire?
Oxygen.
Okay. One other. Nitrous oxide. Yeah. Nitrous oxide. All right. What about ignition sources? What kind of ignition sources are in the OR? Bogey. Yeah. Lasers.
Hormones.
Exposed cords. Yeah. What else?
Your nerve stem, I don't know.
Theory and circuit. Fiber optic scopes. When you leave those on, they heat up like crazy. They start doing thoracic and whatnot. I really want to leave one of those anymore. Drills. Burr holes, drills, this sort of things. Okay. Fuels. What are the fuels found in the OR? That's going to keep the fire going. Okay. Drapes. That's a big one.
Fatty tissue.
Fatty tissue.
Patient hair.
Patient hair. Okay. Laps, gauze.
Oh, the paint.
Paint.
Chloropreps.
Chloroprep. Chloroprep, yeah, so that's alcohol based. Yeah. How long do you have to wait for chloroprep to dry? What's that? 3 minutes. Yeah.
The VA did that with
They wait 30 minutes in the VA?
I'm sorry,
They're like,
that's
"Stop that, break, not let this shit dry."
a long time though, because when you mess it up, you have to do it all over again. But yeah, not 30 minutes, for 2 minutes.
Hey, what's up?
Oh man, really?
Alright.
Oh, nice. Yeah. Yeah, I got them.
Fire
For
safe.
33.
Alright. 3 minutes.
3 minutes.
I mean, let's not try and tell a surgeon to wait 30 minutes. I would like to see that.
Well, the infection risk of the VA is like They're getting pretty serious about it, I guess. Because I bet his eyes aren't allowed to walk out with scrubs anymore.
Oh, really? When I started residency here, the VA residents couldn't work because aspergillosis was in the SPP.
Oh.
Yeah, so they had like fungus coming out on their surgical instruments. They couldn't start. They couldn't do cases for months. That was in the old hospital. All right. Does the method of anesthesia, MAC versus general, impact the risk for perioperative fire? Yes. How?
If you're giving the patient supplemental oxygen, just blowing oxygen in that area.
Yeah, you have open oxygen source, right? Your endotracheal tube should be enclosed surgery unless you forgot to attach something. But yeah, that's the problem, right? Nasal cannulas, non-rebreathers, the drapes, if they're down over the patient's head a little bit, they create like a little closed cavity, right? And then oxygen can actually cool there. All right, does the surgical location impact the fire risk?
Yeah, closer to the base.
Yeah, closer to the base because that's where the oxygen is. Yeah, exactly. When's the best time to discuss this? When do we discuss this? Okay, so how do we reduce the risk of fire in perioperative?
Trace little oxygen as you need.
Or low IO2s? Yeah, sure. Configure the drapes. This is all simple stuff. There's kind of no questions.
You want to keep the suction on like near the patient's face.
I hadn't thought of that one either.
Back here,
Find yourself needing to do that. You might want to reevaluate.
That's soon.
Whole suction metabolized.
Just allow your skin tone to dry. We had an incident here a couple of years ago where we had surgical fire. We had a fire on this surgery site. We were doing axillary cut down for cannulation, and the chloroprep hadn't dried, and the drape was right here, and it kind of cooled in the clavicular area. And the surgeon went to Bovie, and it all lit up. Have you guys worked with Tomas yet? No. Tomas there, isn't it? But he was, he was in there, and he starts slamming down the drapes. So it does happen, right? And there's just a little bit of chlorpep. They gave it, time to dry, but it cooled a little bit. So you just gotta look at this stuff. Really little things. We're moving along. We're charting. We're putting our temp probe in. Turning the gas up. Make sure the patient's relaxed. That sort of thing. But little things go a long way, right? Kind of like we were talking about this morning. Okay, and what about if you have an airway surgery, right? What can you do with your endotracheal tube to help reduce the risk of fire? We already mentioned low FiO2. What else?
There are those weird ones that they do for the ENT cases that go in and they're curved and they're extra long.
Yeah, so there's reinforced tubes. There's also laser resistant tubes. So PVC tubes, they can catch on fire easier, whereas these ND-YAG laser tubes, which you guys will see in the practice questions, it's really annoying. They absorb heat, they don't necessarily just catch on fire. There's something else you can do.
Reduce your flow.
What's that?
Reduce your flows.
Reduce your flows. You can do that, yeah. Mostly it's FiO2. What else? To the endotracheal tube itself. The cuff. So you can put saline or methylene blue in the cuff, right? And the cuff's really thin, right? So if you have something heats up, that's going to melt first. It'll burst. You'll lose your leak, and then surgeons usually work in the airway in other cases. You see the blue leaking out, and then stop everything before something really happens. All right. So, and then nitrous oxide, just avoid the use of nitrous oxide, especially in airway surgery, if you're concerned about airway fire. All right. So, if an airway fire with an endotracheal tube airway fire happens with an endotracheal tube in place, what are you going to do? First down. What's that?
Yeah, take that thing out.
What else are you going to do? What's that?
Turn off the O2.
Yeah.
Don't activate your ringers.
Cut off the gas, right? And then put out the fire, right? Exactly. You got to remove all flammable materials, and you use fingers sailing to put out the fire. First step, though, is a board question. Get that tube out of there. When you pull it out, it's a flamethrower. It is. Jack Humphrey, rest in peace, he used to work at Denver Health. And he used to do this thing with us. Where he'd take us outside in the back, and he'd hook up an oxygen tank to an endotracheal tube and light it on fire. and it was impressive. It was very impressive.
Which is more flammable, nitrous or oxygen?
I don't know for sure, but it's oxygen. It's not much. Yeah, so get that tube out of there. Be careful when you pull it out. Turn off the flows. But first step, they'll try and pin you down. Do you turn off the gas flow first on your question? No, just get the tube out. Okay. Get all the flammable material out of there, and then flood the field. All right, fire's out. What do you do now?
That's breathing again, ABCs.
Yeah, establish your airway again. Right. Mass ventilation. Put a tube in. Smoke inhalation injury is really dangerous. When you have a fire in the airway, you're gonna have particulate matter from those endotracheal tubes too. That can be in there. You gotta get that out of there. Tissue's usually really friable and bloody. Going either way, more swelling, more edema is going to happen. Okay. What about if you don't have? What about if you have fire in the OR, not including an airway or endotracheal?
How do you got fire
In your tube? You'll know.
See it? I mean, the surgeons probably would.
Surgeons will see it first because they're looking at it. Yeah.
So you won't really.
Yeah. But you should be paying attention. Anything having to do with the airway, always be paying attention. Okay. Like most of the time, I wasn't in your room today. I was in the other room because we were doing bronchoscopies. So that's a general paralyzed without an endotracheal tube. So you got to be right there watching. Sort of thing. Okay, so then it's not an endotracheal tube. What are you going to do? You got fire on the drapes near the patient's face.
Trying to look for the fire extinguisher.
Put out the fire, then you just start to smother it, pour ringers on it, whatever you want to do. Get the drapes out of the way. Turn off the oxygen, right? Turn off the oxygen source. It's all the same stuff. Just gotta remember to do it. These are all rare circumstances, but if it happened to you and you're in that situation, you'd want to have a checklist of do all this stuff because it all happens really quickly. And then the other things, there's fire extinguishers in the OR. I don't know if you guys heard that today. Grab those if the fire's not out. Okay? And then you want to, if the fire's still not contained, the whole OR is like catching on fire. You want to activate the alarms, get people to safety, and then get people out of the OR. You need help. And then close doors. Okay. At that point, more people should be around.
What do you do with a patient that's still sedated?
What do you think?
Roll them out on the surgery bed, or transfer them, or
Sack of potatoes.
over the shoulder.
Everybody has to go.
In the NICU, they made these little things, and it's literally like you could put like 4 babies in.
That's awesome.
You could literally like bag them if you have to. We have to do like drills to practice.
That's
4 of us do like 4 of us babies.
That's amazing.
Is it called baby bandolier?
I don't know what it's called.
Alright, so you have an endotracheal tube in, you gotta get your patient out of the OR, what are you gonna do? Ambu bag, yeah, always check you have an ambu bag in the OR. Where are they located? Behind the monitor, yeah. Right? Make sure one's always there. Okay. 4 months ago, I had a cardiac case we induced, and the resident swore the anesthesia machine worked beforehand, and the ventilator just didn't work at all.
Oh shoot.
So I sat there bagging the patient with an ambu bag for an hour while they undid everything, pulled the anesthesia machine out, put a new one in. And what else do you have to do other than ventilate them? They have an endotracheal tube. What's that?
Acute sedated.
Yeah, exactly. So you gotta switch to TIVA, right? Until you're ready to extubate the patient or anything like that.
What did you use for your TIVA since I'm assuming you had horrible cardiac disease?
Yeah. Yeah, he did. I was running Precedex. Yeah. And some ketamine, and then used some Versed too. So, amnesia, and then some sedation. Okay, guys. questions about fire safety and patient position? No. Great. Did you learn something today?
Yeah.
Good. All right. Have fun. Have a good night.
Thank you. I'm hearing about your patients. Just treat your patients like inanimate objects. I like the baby video.
No worries. Caesar, I
I need to like trademark that. So like sell it, like if you have actual bandit.
What is that?
It's my nerd pack.
Sure, what?
It's my nerd pack.
Your nerd